Добрый день, уважаемые коллеги. Я бы хотел с радостью сегодня объявить, что к нам приехал Клаус Герлингер, который нам расскажет о методе тромбоэластометрии, да, в большей степени в трансфузиологии, в гемостазе вообще, как при помощи этого метода можно избежать ненужных трансфузий компонентов крови, как можно эффективно оценивать систему гемостаза, в том числе интраоперационно, то есть в любых практически ситуациях при помощи достаточно простого метода понимать, что сейчас пациенту нужно в плане остановки кровотечения. И чтобы не затягивать вступительное слово, я сразу передам слово доктору Клаусу Герлингеру. Пожалуйста.
Yeah, thank you very much for the kind introduction. I have to first mention maybe three things. First of all, I'm not from Pediatric. Second, I'm not a hematologist. And third, I cannot do the presentation in Russian. So my basic education, I'm coming from anesthesia, intensive care and emergency medicine. In Germany since 2007. We have an on-top specialization which is called a hemostasiologist. So that means we are not the specialist for hereditary deficiencies like hemophilia. We are the specialist in particular for perioperative bleeding problems. So that means I was working quite a lot with our colleagues from Pediatrics because we work a lot with the colleagues from the neonatal ICU, with the colleagues also from bone marrow transplant, with the pediatric ICU in the perioperative setting. But I think it's quite often always interesting to coming from different perspectives. And when we started in our institution about 20 years ago to focus on bleeding management, the most interesting part was our interdisciplinary meetings because everybody could add something from a different perspective. I'm also happy during the presentation if somebody has a very urgent question or just disagree what I'm saying, you can just raise your hand and we can do it directly interactive, or we can do the discussion later on, whatever is preferred for you. Also the Society of Intensive Care in Germany, that is this DV, the German Society, Interdisciplinary Society of Intensive Care. That means intensive care is done by different specialties. So a lot of anesthesiologists, but also pediatric, neurosurgery, cardiac surgery, internal medicine. So it's an interdisciplinary society. And I had the honor between 2010 and 2012 to share the section of hemotherapy. So again, it was very interesting because you learn a lot from the different perspectives of people. And was also working in the European Society of Anesthesiology and was one of the members who were writing the first version in 2013 of the European guidelines for perioperative bleeding management. I stepped back in 2012 because at that time I moved to the dark side of power, which means I'm now working in the industry. I'm the medical director for the TEM company, the company producing the Rogachev device. But again, the most interesting part now in this job is also traveling and meeting with people around the world, and we can exchange ideas how maybe we can optimize bleeding management or hemostasis problems in different settings. A lot of my presentation will deal with the perioperative setting, because in this setting the most evidence and experience using this device is available. But we will also cover, for example, later on, how to use viscoelastic testing in neonatal sepsis, where sometimes it's also a very complex situation. And as we discussed already a little bit outside, a lot of transfusion nowadays, in particular in critical ill patients, is done more or less prophylactically. So we treat numbers. Maybe the INR is high, we think, oh, should we give some plasma? Or platelet count is low, should we give platelets before we have really a bleeding problem? So I think there's more and more evidence available that a more restrictive approach seems to be better for these patients. So just coming back, so why people are doing viscoelastic testing guided or Rogachev guided bleeding management. Nowadays, we understand this as a part of patient blood management. And also patient blood management started more looking just at red blood cells. So it was about, should we increase the hemoglobin level? Of course, also anemia management is important. But now also patient blood management is looking more and more to other blood products. So it's always good to give plasma to our patients. It's good to give platelets in the absence of bleeding. So it's more and more expanding to transfusion overall. And we're not just doing this to save 1 or 2 units of blood products. Finally, we're talking about patient safety. So the question is always, should we give more? Or is even sometimes less can be better and more safe for our patients? It's not my idea. That's more or less the idea from a guy, Hippocrates, from Greece, 2,500 years ago. And of course, the main focus, what we do as physicians, one focus is to cure, but even more important sometimes is to prevent additional harm. And I think also this young guy, unfortunately died, I think, 10 years ago. And we know, yes, working in oncology, we are very close to both. And we want to cure, but what we're doing is also dangerous for our patient. I have actually the experience that my wife has a malignancy, and we just decided to stop chemotherapy because she had definitely more issues with the chemotherapy than without. So we are very close between doing it better or maybe sometimes even harm our patients. So coming back to the definition of patient blood management, so it's not just an idea, so it's a timely application of evidence-based medical and surgical concepts. So it's not just about opinion, it's more and more really based on data. And what we want to do is maintain hemoglobin concentration, not by just giving blood transfusion from a donor, is by keeping the blood into the patient or treating anemia also with other things like intravenous iron, erythropoietin. So sometimes it's better than giving blood from somebody else. It's also important to optimize or stabilize hemostasis. And it's better to stop bleeding, so minimize blood loss, than just to transfuse. But in the end, again, the key is improve patient's outcome. And as mentioned, it's not only one point. We can say the main concept of patient blood management is summarized in this picture. So the first pillar is anemia management. So we have to identify, again, also in the preoperative setting, if a patient comes to surgery and he has already anemia, and that's quite often, we should recognize this early and maybe treat the patient. So that means see what is the reason. Is that an iron deficiency or is that chronic inflammation? And then maybe treat again with iron substitution, with erythropoietin, because we learned even in oncology surgery, giving a lot of blood transfusion has an effect on the immune system, and this again has an effect of the recurrence of a malignancy. So giving a lot of blood is associated with more recurrency of malignancy. So sometimes it's better to pre-treat the patient 2 weeks and then avoid blood transfusion than just say, okay, let's do the surgery tomorrow, but with a high chance of a need of blood transfusion. So anemia management is one pillar. It's not my main focus of the talk today. It's more the second pillar, that is minimize bleeding and blood loss. So hemostasis management, which I think is also important. It's in particular important in situations which I was mainly dealing with, severe trauma. You cannot tell a severe trauma patient, oh, come back 3 weeks later because in between we take care for your anemia. Yeah, we have to take care for this patient. In transplant, it's quite similar. So we are doing about 150 liver transplants a year if you have an organ. You have to decide. We do the liver transplant this night or today, or we have to use it for somebody else. There's no big time for pre-operative management. In cardiac surgery, you can do, if it's not an emergency, but the biggest issue in cardiac surgery are, for example, type A dissections, and again, you cannot send the patient home. And the third pillar, and I think that's maybe also important also in your field, then we discuss about restrictive approach. So is it sometimes better to tolerate some anemia or some thrombocytopenia or an increased INR without treatment, or should we correct numbers? So that's also, I think, something very important also in ICU patient, because we know at a critical care unit or ICU, 2/3 of all transfusions is not done to treat bleeding, is done to treat numbers. And that is questionable if that's really beneficial. So what is the issue? When I talk to US trauma people, they usually say it's very easy. If the patient starts to bleed, we start to transfuse and we give them as much as blood product as we can. And if it stops to bleed, we stop to transfuse. I think it's not really as easy as that, because what we learned in the last years, that inappropriate blood transfusion can be too much, too less, the wrong product. There are good data showing that this increases morbidity, mortality, and also costs. It might be hospital costs. That's the situation in Germany, because the hospital has to pay for all blood products. I learned in Russia, like in Canada or Australia, the government is mainly paying for the allogenics. Maybe you have to pay for factor concentrates and diagnostics. That's a problem, that the savings you have for allogenics is not really beneficial for you. It's beneficial for the government. But overall, somebody always have to pay. And we know that blood products are limited resources, but they're also in principle expensive, and the same for factor concentrates. The next problem, and I think that's for me is a key problem, is I call this an evidence-belief mismatch. So that means nearly every physician, of course, we try to do the best for our patients. But sometimes what we believe is not the same as evidence shows us. So, for example, a lot of people, and that is shown in this survey, so that has been done by Simon Stanworth. He's a hematologist from Oxford, and he was sending around a survey to pediatric ICU units around the world, and he was just asking, what do you think about plasma transfusion? And you see that 43% of all these intensivists believe that plasma transfusion can arrest bleeding. And even 27% believe that plasma transfusion can prevent bleeding. So if you have pathologic lab results in the absence of bleeding, but somebody says, oh, we have to do an intervention or we have to do surgery, say, oh, maybe we should correct it before we go to surgery because it's more safe for the patient. And that means that, of course, if people think like this, a lot of plasma transfusion is giving, even for treating hypovolemia. In Germany, we have a 1A recommendation, don't give plasma for hypovolemia. Then we give volume. It can be crystalloids or colloids or maybe even albumin, but you don't need coagulation factors for hypovolemia. And the second point is that, again, a lot of people who think this give even mildly abnormal coagulation tests. We talk about INR 1.5. They treat it because they think, okay, that's more safe for our patients. Again, so that's a lot of people around the world believe. So what is the evidence? And this is a Cochrane analysis. You know, Cochrane is doing all the meta-analysis. And it's a question, what is the value of fresh frozen plasma in the setting of cardiovascular surgery? And it's based on 15 randomized trials. And if you take the data together, the answer is fresh frozen plasma is inferior to placebo to treat bleeding in cardiovascular surgery. Because the only reproducible result was that red blood cell transfusion increased 2.6 times. I would expect, okay, if we want to have something efficient, we would reduce red blood cell transfusion. The problem is the only reproducible effect is you dilute your hemoglobin level. Because we know, talking about adults, yeah, we need a huge amount of plasma. Going to pediatric, we can even say, okay, you need 10 to 15 milliliter per kilogram body weight. So just really a drop of plasma doesn't change anything in hemostasis. So that means, anyway, you will dilute your hemoglobin level. And whatever trigger you use for red blood cell transfusion, if it's 7 or 8 or 9 or 10, you will reach this trigger earlier. And that means patients who get a lot of plasma gets more red blood cell transfusion. And if we go back to trauma and like ratio-based algorithms, giving 1 to 1 to 1, the red blood cell transfusion triggers again plasma transfusion. So we run in a circle of giving even more and more blood products, and this ends up with transfusion-associated circulatory overload, which is one of the main killers of blood transfusion nowadays. And that's just shown here. That's data already published 5 years ago. It's based on the UK SHOT report, Serious Hazards of Transfusion, and data from the US FDA. And the good news is virus transmission and bacterial contamination, this is very rare nowadays. We can control this by testing the blood product. So yes, the blood product is quite safe nowadays. The question is if this blood use is safe. And we see 2/3 of all transfusion-related mortality is transfusion-related acute lung injury, transfusion-associated circulatory overload, and transfusion-related immunomodulation with nosocomial infection. And you cannot test the blood product for this. Again, this is an over or misuse of blood products which results in these complications. And even if you look at a lot of data, I say, okay, even TACO, Charlie, maybe 1 to 1,000. But I think it's definitely underestimated. That's a study again in critical ill children, and they were looking, what is the incidence of Charlie? 7%. That's 70 times more than 1 to 1,000. So again, it's a matter of awareness. So if you say, okay, we give some blood transfusion, in particular, you give massive transfusion. Some years ago, we said, okay, massive transfusion is always a lung problem. Now, we're dealing with this with less plasma, less platelets, more factor concentrate, and suddenly, oh, we can even have a relatively high blood loss. We replace the red blood cells by cell saving, we replace factors by factor concentrates, and we don't see big problems from the lung anymore. So it not just happens. It happens much more often than most people expect because they just say, okay, that's normal. But it's not normal. The other point is, what's about platelet transfusion? Again, here data from critical ill children. And just looking again how often platelets are given because of real bleeding or more often prophylactically. And you see here again, 2/3 of all platelet transfusion was given to treat a low platelet count and not treat a bleeding patient. And even 21% for minor bleeding, where again the question is, do we really need platelet transfusion? And it's 12% in major bleeding. So that means again, something between 70 and 90% of all platelet transfusion might not be really indicated, but we see there are potential harm by giving platelets quite liberal. And this is a quite huge but observational study. It's a cohort study. But you see it's 40,000 patients. That's from Daryl Core. He is working at Mayo Clinic in Rochester in the US. And they were looking again, and that's mainly adults, what is the impact of prophylactic platelet transfusion in critical ill patients with thrombocytopenia. Of course, the expectation was we avoid bleeding complications. The patients are doing better. What is the result of this cohort study? Had even a significant higher red blood cell transfusion, was even 7.5 times higher. It's more difficult to explain to plasma because it's such a huge volume, but there was definitely no reduction in red blood cell transfusion, fewer ICU-free days, so it means longer stay at ICU, and more organ failure. So there was no benefit, but there was significant harm. Again, that doesn't mean we should not give plasma and platelets to anybody. It just means we should maybe better select the patient, and we should be more restrictive. But again, you might say, yes, that is just a big cohort study. Maybe there's some bias. And you might be right. And therefore, there are a lot of long list of studies. I will just focus here one, which is maybe even more in your setting. We're talking about thrombocytopenia in neonates. And this is a randomized study published in New England Journal of Medicine. And maybe you know, New England Journal is quite careful what they publish. I'm still waiting for my first paper. Up to now, they always reject and say, oh, that's not interesting enough. But here the question was, relatively simple question, is it more effective and safe to take a threshold of 50,000, more liberal, or 25,000 platelets per microliter for prophylactic platelet transfusion in neonates? And the result is more liberal, 60% more mortality. So I think that's a quite strong signal that we should be more restrictive. We even don't know, is 25,000 the right number? Is maybe 10,000 the right number? It's really difficult. And my personal experience is just having the number doesn't tell you anything about the performance of the platelets. I personally prefer 20,000 platelets are working well than 200,000 are not working. And our experience in liver transplant is we are doing in between a lot of liver transplants with 20, 30,000 platelets. If they're working well, it's fine. And we're doing 80% of all liver transplant without any blood transfusion. And looking at the corresponding editorial, so I said in the beginning, less may be more or can be more, and they say less is more. So it's more and more proven that a more restrictive approach, not only for red blood cells, also for plasma and platelets, seems to be the better way. But again, we discussed before, as physicians, we are more trained to do something. It's so much more difficult to train people to say, do less, because we feel uncomfortable to do less. And that's a point where I think viscoelastic testing can help a little bit, because viscoelastic testing is more designed not to look at platelet number or fibrinogen concentration. We're looking at the performance. So how good are these platelets working? What is the rebalance of the system? So we know if you have less platelets, your fibrinogen a little bit higher, that can compensate. In cirrhosis, we learned a lot from the liver patients. If your INR is high, because the liver is not producing enzymes so much anymore, but factor VIII coming from the endothelial cells in a patient with liver disease up to 300% of normal, not reflected by the INR. That shows a rebalance, and viscoelastic testing as a more global test shows better the rebalance of the system. So what we learned is, okay, we can have quite a lot of pathologic results, in particular from plasmatic coagulation test. If the whole blood test shows a rebalance, then we can be much more restrictive, and the data show without any increase in bleeding complications. So what is the solution? I think patient blood management concept, which includes in the second pillar point of care testing or viscoelastic testing, has the potential to implement a much more restrictive approach by identifying the patient without rebalance. So if both standard lab test and viscoelastic testing go in the same way and say, yes, we have a problem with thrombin generation, even I cannot say you have to treat everybody who has an extent clotting time more than 80, but if we already do it this way, we saw that we, again, can avoid 70 to 80% of prophylactic transfusion. We still don't know if we need the 10 to 20%. That's just one study. It's from Miroslav Durila. He's from Prague, working there at an ICU. And in an ICU, you have sometimes the question. And that is all patients with increased INR. And the point was they had to do a tracheostomy. And the concept before was, okay, if INR is higher than 1.5, they give whatever 1 to 2 units of fresh frozen plasma. We can discuss if 1 to 2 units of fresh frozen plasma in an adult can change coagulation at all. But then they say, okay, we run just in this patient with increased PT-INR, a ROTEM, and if the clotting time was shorter than 80 seconds, they didn't do anything. And they reduced up to 90% of interventions without any increase in bleeding complications. And just this year, they more or less repeated this with children. You know better than me, doing studies in children, just from a legal point of view, is so much more difficult than in adults, because you cannot ask, you can ask whatever 2-year-old child, are you happy with being part of a randomized trial? It doesn't matter what they answer. Asking the relatives is also complex. So we all know getting evidence in pediatric patients is a much bigger challenge than in adults. But since they had the results already in the adults, they use the same concept. And again, if the whole blood test showed a rebalance, they said, okay, we can avoid the prophylactic intervention with normal ROTEM results, and the same as in adults. You could be much more restrictive without any increase in bleeding complications. Coming back to pediatric patients, that's from Columbia University in New York. And the question here was, again, it was a study done in patients with thrombocytopenia, always below 30,000 platelets. And the question was, is platelet count or clot firmness? I use the amplitude after 10 minutes in the X-stem. And is that the better predictor for bleeding? And it's overall 130 patients. As just here 3 examples, and you see the platelet count was quite similar, something between 10 and 15,000. And the interesting point was, if the amplitude after 10 minutes was higher than 35 millimeters, no bleeding with any platelet count. So that means the acute bleeding score was 0. If the A10 was below 25, then there was high bleeding incidence and high bleeding severity. Unfortunately, there's not one single number, let's say 30, which means 31 never bleeding and 29 always bleeding. There is a gray zone, you see, of about 10 millimeters. And what we learned, that seems to be the area where, for example, there might be a compensation by functionality of platelets and what is the level of fibrinogen. Because if fibrinogen is quite high, again, we can tolerate lower platelet count. The worst situation is low fibrinogen and low platelets, and maybe low factor 13, and a platelet dysfunction. So, of course, it's not one single number. We have to look at the pattern of these patients. But again, there's a quite strong signal, and repeated by others, that the functionality is much better predictive than just the number. We can translate this because in Europe we use more the A5, so it's more important when you have severe bleeding, because then 5 minutes can count. If it's a situation for prophylactic 10, it doesn't matter if you have to wait for 10 minutes or 5 minutes, but it works with both parameters. Of course, we have also, and a lot of people from the pediatric field, okay, we cannot transfer data from adults to children. Children are not just small adults, and I completely agree. So, of course, we had to look what are the difference in the hemostasis system in children compared to adults. So also, of course, reference ranges have been done, and you see it's a quite big study. We're looking what is in the first 3 months, what is in the next 6 months, so up to 1 year, what is in the second year, what's from 2 to 5 years, 6 to 10, 11 to 16. I think everybody agrees that after 16 years it doesn't make any difference anymore. But what we see from viscoelastic testing, the biggest difference is really in the very small ones. So the first 6 months to 1 year, after this time, there's not really any more big differences. It's even sometimes in adults more, because if you take a blood sample from a young adult, there's usually not a lot of inflammation. If I take one from 70 years, the fibrinogen level is much higher. It's not because they need more, and they have more inflammatory diseases, which increase the fibrinogen level. But again, so there are a lot of the reference ranges available. The negative point is we don't use reference ranges for therapy. Why not? Reference ranges are for healthy volunteers. We can discuss volunteers in pediatric with 6 months again. But the point is, when we have algorithms in bleeding settings, we develop our cutoff values not with reference range. We do observational trials, and then we do a ROC curve analysis, and we say, what is a cutoff in cardiac surgery, or in livers, or in trauma, which has a higher sensitivity and specificity to predict the clinical endpoint of bleeding. And that has nothing to do with reference ranges, because reference range is like a convention. I don't know exactly when, let's say 20 years ago, we decided a reference range is a 95% confidential interval, is mean plus minus 1.96 standard deviation. If at that time the decision was made 99% confident, that would be 3 standard deviation. 75 confidence would be 1 standard deviation. Maybe the patient don't know about this, so they don't really follow the concept that if it's normal, they don't have to bleed, and if it's pathologic, they have to bleed. So again, it's important to know, because we have to know the pathophysiology, but that's not what we exactly use for therapeutic decisions. There's another one, so we have even reference ranges for preterm neonates and full-term neonates. It's even a little bit more challenging to do that. And one challenge is, of course, the blood volume of these patients is very low. So even, unfortunately, therefore we have only the reference ranges here done by this group from Greece. They only use the extent. Because the more tests we are running, the more blood we need. And in particular, in such a study, of course, there's no benefit for the patients. We have to be very careful that we, again, even just by a reference range study, don't do harm. But it helped us, of course, to understand, and that also in this setting, arterial blood samples are the same as venous blood samples. So we have an idea. And what we saw was that even these neonates have a little bit more fibrolytic activity. Might make sense, because the vessels are very small. So if you get any clot, it should be eliminated as soon as possible to prevent organ failure. So it's interesting to know, and it's available, but I think it's not the most essential part. So just to explain the concept, how we work in the preoperative setting, I just show you 2 algorithms. That is for pediatric liver transplant, because we do quite a lot of pediatric liver transplants, not in neonates. Usually for livers, we weigh that they have a body weight, if possible, of 5, 6, 7 kilograms. It's more for the surgeons, because doing anastomosis in a neonate is even more challenging. That's challenging enough. And then we have this concept. That is a similar concept as in adults, but again, we use different cutoff values. Again, based on observational studies. And the most important point is the first one. A ROTEM or TAC cannot tell you if the patient is actually bleeding. So if there's no bleeding, we don't treat numbers. So that means if the answer to the question, is there diffuse bleeding and do we have to consider an intervention, is no, the algorithm stops. So we don't treat numbers in this field. The second question is there any kind of hyperthrombolysis? Also, hyperthrombolysis managed is very different from setting to setting. You know, in cardiovascular, a lot of patients get tranexamic acid just as a routine. In trauma, and in postpartum hemorrhage, fortunately, there's no postpartum hemorrhage in pediatric patients, because they're usually at the other side of birth giving. But just to mention that in severe trauma, severe postpartum hemorrhage, based on the CRASH 2 study, the woman study, in the first 3 hours, we are very liberal. We don't wait for the results. Severe bleeding means give a single dose of tranexamic acid. In livers, we are more careful, because we learned that giving antipholytics very, very liberal they don't create thrombosis, but if there is already thrombosis, and that is in at least 50% of patients getting liver transplant, they might be a growth of the clot. And the most feared complication, in particular in pediatric, is hepatic arterial thrombosis. Because that happens, the chance is very high that you need a new liver again. And retransplant is not something which makes anybody happy, and in particular is a high risk for the patient. So that means we are more restrictive in liver transplant. And also the pathophysiology of hyperformalized is completely different. They get hyperformalized in the anapatic phase because there's no liver. The main therapy is reperfuse your new liver, and in 80% it's just self-limiting and it disappears. And we say, okay, that's not the problem. So we say, no. So the concept is like a flight checklist. It's always a yes or no. If we say no, and then we look at clot firmness. So we use the so-called XSTEM test. That's a test where we activate with tissue factor. We have the whole blood, and we see the combination of the fibrin clot and the platelet part. And this is reduced. The question is that mainly a problem of platelets or fibrinogen? And therefore we use in combination the so-called FIBTEM. That's a test where we knock out the platelets completely, pharmacologically, with tutushaldazine D. And this is reduced too. Then the main problem is a low fibrinogen or even a fibrin polymerization. What does it mean, fibrin polymerization? If we give a lot of colloids as volume replacement, has a negative effect on fibrin polymerization. Or the patient has a factor 13 deficiency too. We might have enough fibrinogen, but we get only fibrin fibers, no cross-linking. So that doesn't work. So we have to think, if this is low, we need fibrinogen or 13. And then, and that's maybe important in particular for pediatric, you cannot say as an, we just give one vial. Because a 5-kilo child is not the same as a 15 or 25. So we try to do as precise dose calculation. And that means if we have here the situation of a low FIBTEM, and just as an example, let's say the FIBTEM is here only 2 millimeters, and we target 10 millimeters. So the target we get with interventional studies. Then we need an increase of 8 millimeters in FIBTEM, and that means we need 50 milligrams per kilogram body weight fibrinogen, and that would be 2.5 milliliters per kilogram fibrinogen concentrate, or about 4 milliliter per kilogram body weight cryoprecipitate. It works better, the calculation with fibrinogen concentrate, because that's a standardized product. And I don't have any experience with cryo because I started with medicine in 1986. It was already taken from the market in Germany. Because, in the 80s, there were a lot of patients. You use cryo for hemophilia A, and it was not virus inactivated, and a lot of patients get HIV infection, hepatitis infection. At that time, we had in Germany already a lot of virus inactivated factor concentrates, not only factor 8, factor 9, also fibrinogen, 4-factor PCC. So cryo was taken from the market because if you can avoid virus transmission, you should avoid virus transmission. So again, I don't have experience myself with cryo because it's used in Germany, fibrinogen concentrate only. Situation in Russia is just maybe the opposite. You have cryo, you don't have already fibrinogen concentrate. Calculation with cryo is not as exact because there's a quite huge variation. You might have 8 up to 16 gram per liter fibrinogen. So that means it depends on the donor, it means it depends on the preparation of cryo, but it can be quite used for even better dose calculation. So it's done in studies like in Korea where they also use cryo. Again, it's not as reproducible as fibrinogen, but better than no dose calculation. If we say, okay, FIBTEM is not the problem at all, then we think in bleeding about platelet transfusion. You see this number is quite low, quite close to the number from Columbia University in New York in a pediatric oncology patient. So, of course, there's some difference because they get surgery. So they need a little bit more because they have a bigger challenge. And what we're doing more and more is doing platelet function testing. Because viscoelastic testing, we always create a huge amount of thrombin. So we add tissue factor or ellagic acid or kaolin. That means every single molecule of prothrombin in the cup will be converted to thrombin. So it's really an overstimulation of platelets. In platelet function testing, we use a very specific amount of arachidonic acid, ADP, or thrombin receptor activating peptide. So that makes the stimulation lower, but much more sensitive to small effects. What was thought a long time is that, oh, you always need 100,000 platelets to run platelet function testing. That's not really true. Of course, if you want to have reference ranges, yes. But we can even see with lower platelet count what is the performance. So we do this in liver transplant, where nearly no patient has 100,000. We're actually running a very challenging study in Colombo. We're looking at platelet function in dengue hemorrhagic fevers. We're talking about 10,000 platelets. We don't exactly know it will work. We only look at the thrombin pathway because arachidonic acid and ADP is definitely too low or too small or too weak. And we look at the same time of FIBTEM. So maybe there's a compensation. Some patients with 10,000 are bleeding, some are not bleeding. Maybe the difference is the functionality, or maybe the difference is the compensation by fibrinogen. Coming back to the liver, only if clot firmness is okay, we look at thrombin generation. That's very different to TEC protocols. A typical TEC protocol is first looking at R time. If R time is prolonged, always give plasma. Then they look at maximum amplitude. If maximum amplitude is real, they always give platelets. And the third one is alpha is flat, give fibrinogen. What we learned is if you don't have fibrinogen, you can create as much as thrombin as you like. It will never result in a clot. So the precondition that thrombin can build a clot is fibrinogen. And you see even here, we say only use this number if FIBTEM is high enough. Because the second thing we learned is if fibrinogen is low, clotting time is always prolonged. But then we would treat with plasma, low amount of fibrinogen, not very effective, or PCC, even no fibrinogen at all. Prothrombin complex concentrated factors 2, 7, 9, and 10. So we would do the wrong intervention. Then the other reason is safety. We learned that giving fibrinogen, the substrate, has a lower risk of thrombosis than increasing thrombin generation. We learned this from the recombinant factor 7A studies in livers in trauma. It was not very effective to reduce bleeding, but we had always a 10-fold increase in thromboembolic complication, in particular arterial thromboembolic. And stroke and myocardial infarction is not what we really want to have. So it's summarize efficiency and safety. And the concept is treat first what kills first and give last which has the highest complication rate. And then when thrombin generation is not the problem, or we did our therapy, we give every therapy about 10 minutes time to work. We know there's no drug for hemostasis in the world. You inject it, and 2 seconds later it's working. We know the hemostasis takes some time. So that means it depends on the severity of bleeding, 10 to 15 minutes. Sometimes just waiting 5 minutes longer can be very effective. But if we say clinically there's ongoing bleeding, then we take a new blood sample and run the protocol again. So it's nothing what we do in fixed time points, I'd say run and rotem every half an hour, like sometimes blood gas analysis. If there's no bleeding, we don't run a rotem. With ongoing bleeding, we continue until we fix the problem. It's a similar protocol for cardiac. Again, it's the same more or less sequence as for adults, but different numbers. The first question is the same again. No bleeding, no therapy. Hyperthrombolysis, as I mentioned, is most of the time not the problem. So therefore, it just says in addition to the local protocol. So if you give every patient tranexamic acid, even by an infusion, which we never do, usually you cannot expect to have hyperthrombolysis. But we should keep it in mind. An important point is, of course, heparin prothrombin management. And that's something we also learned. protein overdose is the worst thing we can do. So that means a lot of people think, ACT is measuring heparin. It's not really true. It's measuring we have a problem with thrombin generation. So a prolonged ACT can mean a residual heparin effect, a protein overdose, a low fibrinogen, a deficiency of enzymatic factors. So that means in cardiac surgery, if we win from bypass, we measure our ACT, there's no bleeding problem, no protein measurement. If there's a prolonged ACT and bleeding, then we measure, because with the INTEM-HEPTEM combination, that's intrinsic activation with and without heparinase, we can exactly say why ACT is prolonged. Is that really a residual heparin effect or protein overdose? With FibTEM, we can say this is because of low fibrinogen. So we can much more exactly and precise say what is really the reason for prolonged ACT. And then again, the same concept, looking at fibrin as well as platelets. Of course, platelet function testing in cardiac surgery is much more important, not because of the pediatric patient on aspirin and clopidogrel, but we know running a cardiopulmonary bypass is one of the best killers of platelet function. We just give heparin. Heparin doesn't inhibit the platelets at all. So my idea for the future would be if we would have a very short-acting antiplatelet drugs, we could let the platelets sleep during cardiopulmonary bypass, and then we switch it off, and they are back again, would be perfect. There is one drug in a similar way, would be prostacyclin. But unfortunately, there's a lot of effect on hemodynamics. So we use this in patients with heparin-induced thrombocytopenia, which we still run with heparin. Then we can really let the platelet sleep, and if we stop it within 5 minutes, it's gone. It's very nice, but it's very expensive and has some serious side effects. Clotting time again, so the same concept is just showing. The point is always the same concept, and make it as simple as possible, because we also know not every anesthesiologist in operation theater is an hemostasis expert. So what we try to do is develop a protocol which can be run by nearly all anesthesiologists. It was just because I'm a little bit lazy, because before we had the protocol, I was called 3 times a night if I was on duty or not, because we have a problem here or there. When we implement the protocol, I was called 2 times a month, so better for my sleep at night, and maybe also even better for the patient. The very important point is, and that's in the beginning a misunderstanding of people who adapting to protocols like this. In the beginning, they have the tendency to treat numbers. So they measure not now the fibrinogen, they measure the FibTEM. Oh, the FibTEM is only 3 millimeters. We should give fibrinogen. And is the patient bleeding? No, but maybe he starts to bleed. Again, this is a not to do protocol. So step by step, we exclude reasons for bleeding. And then people say, yeah, but my patient is bleeding and the rotum is completely normal and platelet function is normal. Maybe they have big holes in the vessel. Maybe we need the surgeon, because if there's a big hole in the vessel, we don't need factor constant, we need a suture. We call this a Prolene insufficiency. So I need more sutures or a clip. So it can discriminate between coagulopathic bleeding and surgical bleeding. And surgical bleeding needs a surgeon and not factor concentrates. Again, one very important point, and that is when we compare standard lab tests and point of care testing. One is the performance, but the other one is turnaround time. Again, if you have to do a decision maybe in 2 hours, okay, it's not a problem. If you wait 45 minutes for a standard lab test, no big problem. For us in severe bleeding, and a pediatric patient is losing 50 milliliters per minute, that's a very big problem, not for an adult. Even maybe 20 milliliters per minute is a big problem for a small child. So that means in severe bleeding, we need data in a short time. And that's just a study. It's from Thorsten Haas. He's working in the Pediatric Hospital in Zurich, in Switzerland. He did this study still when he was working, I think, in Innsbruck in Austria. And he was just comparing turnaround time from standard lab tests was in mean or median 53 minutes. That's what we usually have, 45 to 60 minutes. I don't know if it's quicker in Russia, but I have some doubts. Usually it's between 30 minutes and even 1.5 hours. And when they were running a ROTEM was 23 minutes, and that was even ROTEM in the lab, so with the same transport time. And then they were measuring ROTEM at the point of care, was saving again 11 minutes. Now we talk about 12 minutes turnaround time. That's a quite reasonable time. We sometimes can wait and then do really the right decision. And how we can do that? You know, if you run a tech, first of all, the R time based on kaolin is already 4 to 8 minutes. So that's the time where nothing happens in the testing. And then usually you have to wait for the maximum amplitude, and that takes again 20 to 25 minutes. So also turnaround is quite long. And that's the reason we developed and validated the amplitude after 5 minutes or 10 minutes or 15 minutes, and what is the correlation to the maximum clot firmness? And that is 0.98. So that means we can use already the clot firmness after 5 minutes for decision making. So that means we have an R time or CT of 1 minute, not 4 to 8, and then 5 minutes. So even with pipetting, it takes about 10 minutes to get the results we can use for interpretation. And in severe bleeding, every minute counts. And that's just again from Torsten Haas. So we both were in the European Bleeding Management Guidelines responsible for the chapter for children. And one important point is, of course, since the blood volume is so much smaller, dilution happens so much quicker. So we don't need to give a lot of crystalloids or colloids to small children to have a dilution. That means delusional coagulopathy happens very quickly. Even if we do cardiac surgery, we just may do the priming for the bypass, and we have already significant dilution. So that means a drop down in fibrinogen happens so much quicker. So this is one of the most important things that we take care. What is the fibrinogen level? And maybe replace fibrinogen before we even have to replace red blood cells in this patient population. And there are several studies. One center had a lot of experience with pediatric cardiac surgery, Gothenburg in Sweden. That is Birgit Romlin from anesthesia, and Anders Jepsen, he's a surgeon. And they did a lot of studies also using the ROTEM. And they used in the beginning mainly the HepTem, that's intrinsic activation with heparinase, because we want to measure sometimes already on cardiopulmonary bypass to see if we run into problems afterwards, and the FibTem. And why we can use the FibTem also? Because all our extrinsically activated tests, XTEM, FibTem, and UPTEM, have polybrain inside, not heparinase. Why heparinase? Heparin is an enzyme, needs at least 1 to 2 minutes to metabolize the heparin. Polybrain is like protamine. It antagonizes up to 5 units per ml immediately, but cannot eliminate more. But this is usually enough for the amount which we have on bypass. So that means, in particular in centers who need cryo, which is not immediately available, and that's, for example, in a lot of studies in Canada, Australia, they measure in complex cardiac surgery, and a lot of pediatric cardiac surgery is quite complex. It's not as simple doing one bypass, because that's not their problem. You can measure, for example, at declamping of the aorta, about 20 minutes before weaning from bypass, and if we see fibrinogen is very low, that means we can communicate already with the blood banks that in about half an hour, the chance is very high that we will need cryo. Because then they can prepare already. We don't give it at that time, but they can prepare, and that means when we say after weaning from bypass, we have bleeding, we get it in a much shorter time. Because it's a time to treat and not the time to have the results, which might stop bleeding. And this is a very important concept, again, that we don't treat numbers. You see here, that's more or less 4 situations. One is insignificant bleeding and normal ROTEM. Then it's very easy to say why we should not existing bleeding with normal ROTEM results. We don't do anything. Very easy. But here, insignificant bleeding, abnormal ROTEM. Also no therapy. We don't treat numbers in the absence of bleeding. Significant bleeding and normal ROTEM, we might talk to our surgeons that we might look for a reason for bleeding. We do the same in adults. You know, if you wean from bypass and you did a lot of cabbages and one is on the guarantee at the back side of the heart. Nobody likes to luxate the heart after weaning from bypass, because you luxate, it's not really have any cardiac output anymore. But if we do it, we always find the bleeding source at the backside. It's much better to do this in the operation theater than going to ICU, and then you get a pericard tamponade, and then you go more or less under resuscitation back to the operation theater, and you have a lot of and then you have to luxate the heart. It's not really fun. So our concept is really fixing the problem in the operation theater and reduce resurgery as much as possible. And then, of course, the interesting part is significant bleeding and abnormal ROTEM, and then we use a protocol as shown before to fix the problem and again also avoid resurgery. And you see from this quite old study, you see red blood cell transfusion was going down, plasma was going down significantly. I have to say our plasma transfusion rate in cardiac surgery is 0.2% of the patient population. So within 2,500 patients we do cardiac surgery per year, it's about 4 patients per year where we give plasma. Platelets were going up a little, and of course fibrinogen is going up, because that is not so reckoned with ACT or even with platelet count INR. So by recognizing, and in particular, again, in the pediatric population, that dilution is a much bigger problem than in adults, so fibrinogen is very often the main problem of coagulopathy in this setting. So they come to the conclusion that a TEM-guided transfusion protocol reduced overall proportion of patients transfused, and it changed the pattern. So before, there was a lot of plasma and platelet transfusion, and then by measuring, they reckon, fibrinogen is much more often the problem, and of course that changes what kind of products are used. Coming back a little bit to the cardiac population and weaning from bypass. And this is a typical situation. What we see here, normal clotting time in INTEM is about 240 seconds, 620. And you see then even clot firmness is increasing very slowly. To be honest, it's not cardiac surgery. It's a 6-month-old girl after liver transplantation at reperfusion of the liver graft. But what we also learned, we have very often a so-called endogenous heparin effect. So by reperfusion of the liver, and there's always some damage to the endothelial cells during the preservation, this is washed out, and you get for a short time this effect. In livers, it's more watch and see, because after 20 minutes it's more or less gone. But it proves there's no need for plasma transfusion or enzymatic factors. In cardiac, of course, that means, we should give some additional protamine. But the question is, how much? We can use here the INTEM-HEPTEM clotting time ratio. So divide the 621 by 260, that results in about 2.5, and that allows us to calculate again the amount of protamine, because again in PET it's not just give one ampoule, that's most of the time over treatment. So the first who published something like this were coming from Japan, and they said, okay, we consider anti-10A as one of the best measures of heparin concentration. But also in our institute, we don't have 24/7 anti-10A, and at least not in 5 to 10 minutes available. So they were looking at alternatives which are used at the point of care. One is, of course, the ACT. One was APTT. One was INTEM-HEPTEM clotting time ratio. And what they use quite often in Japan is the HEPCON system to calculate fibrinogen and protamine. And then they were looking at the correlation to anti-10A. And you see the correlation for ACT was 0.12. That's definitely worse than flipping a coin. So just flipping a coin is much more cheap, and you can reproduce it or use the coin again and again. Why? ACT is designed for high heparin concentration, that we can even measure heparin on bypass. It's not very good designed for small heparin concentration below 1 unit per milliliter. Even APTT was 0.36, that's very close to flipping a coin, and the INTEM to heparin clotting time rate was 0.72. That's quite good correlation. You cannot use the INTEM alone, because that can be also prolonged by a factor deficiency. By having the heptem, we have more or less our baseline always with us. So we can say which part of prolongation is a factor deficiency and which part is a heparin effect. What we also learned, which is important, that heparin concentration below 0.2 is not associated with more bleeding. So it's even better to have a very small residual heparin effect than an overtreatment with protamine. And we also tried in our center just to reproduce this. We have a spiking blood cell, did a calibration curve, and you see there's really a good correlation. So 0.1 means about 1.5 prolongation, or it's more 1.25. Then 0.4, that's doubled. In the case we had, in this case showed before, it was about 2.5, that's 0.5 units of heparin. And then we can calculate also for the pediatric population what is exact the protamine dose to avoid any protamine overdose. Why is that important? We know protamine overdose already is a blocker at factor 5. It's not good. It's a little bit like have a patient on rivaroxaban or apixaban. It's not really funny. And also it results in severe platelet inhibition, triple pathway inhibition, arachidonic pathway, ADP, and thrombin pathway. So there sometimes patients are bleeding more after protamine than before because it's really a strong platelet inhibition. The other point, and that is, it looks like Japan again. No, that's Germany. It's St. Augustine. It's one of the biggest. They only specialized on pediatric cardiac surgery. And what they show here is that most often a reason for prolonged ACT is a low fibrinogen. So giving protamine doesn't help in any way for low fibrinogen. It even increases the problems if you have a low fibrinogen and then you induce a platelet dysfunction. It's a very bad combination. So these patients bleed more. So that means, yes, in the situation of bleeding and prolonged ACT, again, we run an INTEM and HEPTEM and a FIPTEM, because then we can exactly say what's the reason for this problem. A lot of people years ago said, oh, this is a lab artifact, this prolonged ACT due to protamine overdose. And they were running here, that's from Amsterdam, it is in adults, but they were running a randomized trial. And they randomized a high protamine dose, that is 100% of the primary heparin dose, versus a low, it's 70% of the primary heparin dose. And I even know people who are giving 120% of the primary heparin dose. I don't know what they want to antagonize because there is not more heparin in the patient than given. But what we know, why 70%? We know that usually about 20 to 30% of the heparin is metabolized during the bypass time. So they were looking at transfusion, and you see with a high protamine dose, red blood cell transfusion increased from 19% to 32%, plasma from 0 to 11%, and in particular platelets from 6 to 21%, because we induce more platelet issues. And of course, most people give protamine because we don't want to go back to operation theater, and retroactively goes from 2% to 9%. It's 5-fold more need for resurgery. So that doesn't really make sense. And there's an additional point which is quite important. I told you already that it has an impact on platelet function. It's not already known for a long time. So this study from Eric Ortman is coming from Cambridge. And the primary aim of this study was, and not a big surprise, that hypothermia has a negative impact on hemostasis and also platelet function. So we're running a platelet function testing in major cardiac surgery with hypothermia, and you see, of course, platelet function is going down. If you cool a patient to 20 degrees, if you rewarm a patient, it's coming back, not to the baseline, but to a better level. And then there was a big surprise. Then it's going down like this. This is giving protamine. So after protamine, you have a platelet function as in a patient of 22 degrees, which we know is not really a good platelet function. And if we give protamine overdose, it even makes this worse. And this lasts for at least 4 to 6 hours. So it's not like the effect on ACT. If you wait 10 minutes, ACT is normalized again, but not for platelet function. It's also, again, coming back to Gothenburg. They also were looking at platelet function in pediatric cardiac surgery. And again, not a big surprise. So you start with more or less normal platelet function most of the time in a pediatric, and then, of course, on bypass, all three pathways, arachidonic acid, thrombin pathway, ADP is going down. Yes, we know this. And of course, also they recover. But the interesting point is, this is platelet count. So platelet count keeps for several days relatively low. But platelet function recovers quicker. Why it's recovered quicker? Because big surgery is the best stimulus for bone marrow to send out new platelets. So if your platelets have usually a lifespan of maybe about 10 days, and you have only platelets which are 1 to 2 days, they're very young and active, that means even with a still low platelet count, the function is even normal, but even might be hyperreactive. So that means sometimes we run into problems that we get microaggregates from platelets even with a low platelet count. So again, function is not the same as numbers. And that is something we also see in adults. Is not only important if one pathway is inhibited. You see, one blocked is no big difference in transfusion to all of them are fine. And we know only a patient aspirin. It's not usually a big problem. But if 2 or 3 pathways are blocked, then we have an exponential increase. So that means in adults, if the patient is clopidogrel, we not only run the ADP test, we also look what is going on in arachidonic acid and thrombin, and also other authors like Marco Ranucci from Milan showed if the thrombin pathway is very strong, it can even compensate for a blocked ADP pathway. So it's like, usually I say it's like a street. I know you don't have traffic jam in Moscow, but if you have a street with 3 lines and one is blocked, okay, you can still go. But if 2 or 3 are blocked, you have a big problem. And that's the same with platelets. So it's really dependent on the number of pathways inhibited more than the absolute inhibition of one pathway, which is correlated with the bleeding situation. So again, that's just the conclusion here that intraoperative platelet dysfunction was associated with increased transfusion requirements. So just running a platelet function test before surgery doesn't mean you are safe in a particular long procedures because this is changing within minutes. So intraoperative platelet function testing, I think, is very important in this patient population. You might say, okay, all nice concept, but does it really work in clinical practice? So we have even also in pediatric patient a randomized trial that was done in Japan. They did first an observational trial. Again, they defined the cutoff values, used the cutoff values to develop the protocol, then using the protocol to run a prospective randomized study in 100 patients. And what we see is there's a significant reduction in blood loss since it's pediatric. It's not about units or something. It's 16 milliliter per kilogram body weight. It's going down to 9. There's nearly 50% reduction in blood loss. When we look at transfusion requirements, it's from 23 milliliters per kilogram to 11. There's even more than 50% reduction in transfusion because they also were a little bit more restrictive. And it has even some effect on the duration at critical care. It just means, okay, if we avoid complications, we can give the patient earlier back to the normal ward. But as mentioned before, stop bleeding is one point, thrombosis is as worse as bleeding. This is a study from Harvard University, again, the pediatric hospital, and their main problem was not so much bleeding, but they said we have a too high rate of thromboembolic complications after pediatric cardiac surgery. And they were just giving therapy blindly. So we're not running viscoelastic testing, and we call this therapy in Germany a fridge, which means if you have bleeding, you open the fridge and give everything which is inside. You give plasma, platelets, cryo, recombinant factor 7A, PCC, just to stop bleeding, which quite often can result in overtreatment of these patients. And in this study, which was just observational, they were running a rotem analysis at admission at the ICU, and they wanted to know, can we already see with this analyze if the patient will develop a thrombosis? And when they looked at the clot firmness in extent with a cut-off of 69, you see they have a prediction about 70%. And if you look at the FIBTEM, it was 22, it's about 80%. It's quite similar to adults. In adults, it's 68, and for the FIBTEM, it's 24. So not so big differences, but it shows this is a hypercoagulability due to an overtreatment of the patient. So it's like a panic attack. Let's stop the bleeding as soon as possible. And in particular, if you give everything just by, hope the right intervention is inside. So you see here, if there was no transfusion necessary at all, 0% thrombosis. If transfusion was done, 11% thrombosis. What people some years ago thought, what do you prefer, bleeding or thrombosis? The point is, if you have more bleeding, you have more thrombosis. So the point is, we prefer no bleeding and no thrombosis. And then we see you more combinations we do just by, platelets alone is not working. It was 3%, platelets and cryo is 14%, platelets, cryo and recombinant factors is 30%. So you more we just give without really knowing what is needed, the risk of thrombosis is significantly increasing. So the conclusion was here that in the absence of viscoelastic testing, coagulopathy was overtreated, and that's very easy in a pediatric patient to overtreat. But we could already identify at admission at the ICU who was overtreated or not. That doesn't mean we should just use it there, may do more anticoagulation in this patient. It's much better, of course, to avoid the overtreatment. Going to another setting, that's not so much what we do, but Thorsten has, is craniosynostosis. It's a big procedure in small children because you open all the sutures, so usually a big blood loss. And again, the main issue is dilution. So fibrinogen is dropping down in these patients very quickly. Giving plasma is not very effective. There's a very low concentration of fibrinogen. It's just here showing in one case. So that was the baseline. Then we have some dilution. FIBTEM is going down to 7. And with 25 to 30 milligrams per kilogram fibrinogen, they restore and you stop the bleeding. So that means you can do this quite quickly, in particular with fibrinogen concentrate and very reproducible, and avoid completely fresh frozen plasma transfusion. They also did a randomized trial because the question was, is craniosynostosis the same as scoliosis? First of all, the age is not usually the same, but also the size of intervention is not the same. And that just shows having reference ranges doesn't really help you. We have really to see, is that the same setting or is that different? And what they showed was that, the concept was in the conventional group, just using a trigger of below 8, and the more aggressive group, giving already fibrinogen when the MCS was below 13. And what we see is for the scoliosis, it doesn't matter so much. So 8 is still enough. But for the craniosynostosis group, there was a significant difference in other transfusion requirements. So using the higher trigger, 13, seems to me much better. That's close to what we do in postpartum hemorrhage. So again, using a fun-fits-all approach, we have really to individualize it to the patient population and to the kind of surgery. Yeah, coming a little bit to trauma, is not so many data available because already in adults it's very difficult to run randomized trials in trauma, because if you get a severely traumatized person and you say, are you willing to participate in a randomized trial, and you can think about 1 hour, I come back, and then we randomize you to a goal-directed approach or to one, it doesn't really work. It's similar in postpartum hemorrhage. You cannot do this way. But of course we have observational trials, and this is even coming from the US, so the country of 1:1:1. And they said here for pediatric trauma, running an XTEM at admission first allows you to identify which patient has really a trauma-induced coagulopathy, because that's only 25% of trauma patients. 75% have no coagulopathy, no value of giving a lot of plasma and platelets. And even they could predict the risk of mortality and disability after discharge. It's not helpful for the single patient to predict disability, but it's more helpful if you really have to activate a massive transfusion protocol, or again, if you over-resuscitate your patients. And this is done in mainland China. It was a little bit surprise for us because Rotem is not approved in China. But this is a study over, you see, of a 10-year period from 2007 to 2017. For me, it was a little bit okay, maybe in China, if you have good relationships, in particular political relationships, and maybe it's not approved, but you say you need it, maybe you get it. And they even used here fibrinogen concentrate and 4-factor PCC is again not approved in mainland China, but in some specific centers, maybe they get when they say we need it. And they did a quite big study. That's 600 patients, the same size as a US proper trial, which cost $60 million in adults. And they showed again that it was associated with a significant reduction in the interval from admission and trauma-induced coagulopathy was treated. And that's also shown in the US studies. The time to hemostasis is extremely important. The quicker we can stop bleeding, the better it's for the patient population. Less plasma transfusion, because it's not very effective, and a favorable coagulopathy recovery. So overall was less transfusion. Again, we see here the interval from sampling to results. You see what we saw before. Standard lab test, about 50 minutes. Rotem here, 21. This is done in the lab. We do it point of care, it's even quicker. RBC transfusions, or red blood cells, was dropping down. Also the interval from admission that it can be used. Plasma transfusion was from 20% to 12%, so also less plasma transfusion, and also the identification that this patient needs fibrinogen. And with PT, PTT, platelet count, you even don't identify this patient. So there was a move again to more early fibrinogen substitution, which was much more effective to stop bleeding and treat the coagulopathy than giving huge amounts of plasma to this patient population. And also that they were still had a coagulopathy after 24 hours. It was 11% in the plasmatic group and only 6% in the Rotem group. So also we know if they are over days coagulopathic, that's really bad for these patients. And also when we look at outcomes, so total number of hospital days, they could even reduce by 1 day. So overall, it was a much better outcome. So the conclusion was that also in pediatric trauma, the Rotem assays reliably detect the deficiency. You get the results in a much more timely manner, and that allows guiding coagulation therapy with early administration of fibrinogen. And if really thrombin is an issue, that's maybe in 5%, then we can treat this much more effectively with less volume and a better calculation with PCC, so in particular in pediatric patients with blunt trauma. So coming to the final part of the preoperative management, of course, there was a Cochrane Allies already about viscoelastic testing in 2011. There was one single randomized study. It was from Linda Shaw-Leserson from New York, and Cochrane said what Cochrane usually said: we need more data. In 2016, now we have 9 randomized trials, or at that time it was 9, now it's 14 available. And for the TEC, there was not already a significant reduction in mortality, but with the Rotem studies, there was a significant reduction, and the risk ratio is 0.44. That means 56% reduction in mortality. Of course, only in complex procedures. If you don't have bleeding, Rotem will not reduce mortality because it cannot fix a problem which does not exist. So that means, in particular, of course, in bleeding patients with coagulopathy, then we have a chance to improve. And we even take the TEC with us in the overall analysis, and it's still nearly 50% reduction. So it seems to be quite effective if we have a bleeding problem, not for correcting numbers, for a bleeding problem. The other point, I think this is very important, is the need, so acute kidney injury with a need for dialysis. You might say, okay, we have dialysis. We can't put a patient on dialysis, so what? And maybe in 3 days they recover and we put them away from dialysis. What is the point? What we know in between is, for adult cardiac surgery, but also for pediatric, if a patient develops an acute kidney injury, this has an effect on long-term outcome. And it's also shown, this is for adult cardiac, so you just see looking at here, for example, 5-year survival, no acute kidney injury after cardiac surgery, 90% 5-year survival, any acute kidney injury, 70% 5-year survival. It means 20% of our adult cardiac patients die within the next 5 years, not in the hospital where cardiac surgery has been done, if we not avoid acute kidney injury. And this is for pediatric patients, and we see again, acute kidney injury is a very important factor for long-term outcome. So it's better to avoid acute kidney injury than to treat acute kidney injury. And therefore, one of my main focus in bleeding management, or one of the key performance parameters, is avoiding any organ failure, if it's lung or kidney, because we know this has an effect not on early mortality, but even more on long-term mortality. So more or less to summarize this, what we are doing is more or less precision medicine. It's coming from oncology. So more or less you invented this by knowing even not every patient responds in the same way to the same chemotherapy. Sometimes we have really to check. It can be genetic factors, it can be other factors to select the best one for this patient. But this is quite the same for bleeding management. There is not a magic bullet. It's not plasma, it's not recombinant factor 7, it's also not fibrinogen or PCC. We have really to identify what is the specific problem, then we can do a targeted treatment, and that improves outcome. I sometimes compare this to hemodynamics. Somebody comes to your operation or to your hospital and say, okay, you measure blood pressure, heart rate, and cardiac output. It's not necessary. Take 1 liter of Ringer saline, add 1 ampoule of epinephrine and 1 ampoule of norepinephrine. So give something for volume, something for cardiac output, and something for vascular resistance. And then you don't have to measure hemodynamic anymore. We would tell them, you're a stupid guy. Leave our hospital. That doesn't make sense at all. But if somebody is coming and saying for hemostasis, use 1 unit of red blood cell, 1 unit of plasma, 1 unit of platelets, then you don't have to measure hemostasis. 80% in the world is doing like this. But I think it's as stupid for hemostasis as for hemodynamic. I want to cover one last field, if we have the time, and this is using viscoelastic testing in sepsis. It is, of course, also quite complex situation. And the most important thing we know, just giving a blood product or something, the main, of course, therapy is avoid or eliminate the infection. So we are talking about the link between infection and hemostasis. Again, if we don't fix the problem of infection, everything else we are doing is maybe cosmetics, but we understand, I think, a little bit more what is going on in sepsis. And there has been also in JAMA 3 years ago a new definition where we say this is a dysregulation of the response of the body to infection. And that can go in 2 different directions. The body can be hyperreactive. Then you might die early due to multiple organ failure because it's hyperreactive. We get a lot of clots in the microcirculation and the patient die on multiple organ failure. Or, and that might be, for example, in patients, of course, with a bone marrow transplant, the patient cannot react anymore adequately. Then we have the problem that, the bacteria just spreading in the body, and you die because the bacteria are stronger than the body. But it should be somewhere in between, so that you not hyperreact, but that we react adequately. And we have some possibilities to measure. And why? There's a very strong link between infection or the immune system and hemostasis. Maybe you know there are some animals, like horseshoe crabs, they have no vascular system. but they have a hemostasis system. And say, what is the reason for that? That doesn't make any sense. Yes, it makes sense, because the primary task of hemostasis was to fix pathogens. So therefore, the body is regulating up fibrinogen in infection is better to fix pathogens. And they down-regulate PI1, or they upregulate PI1 so to inhibit the thrombolytic system. And what the bacteria are doing, they produce streptokinases, not that we can produce a drug from it, that to set them free again. So there is, again, a very strong link between hemostasis and infection, and that's the reason that a lot of patients with infection develop a DIC, a hyperreactivity first of the coagulation system, with microaggregates in the microcirculation, and they're not cleaned anymore by the thrombolytic system, and that results in organ damage. So, just to come back, of course we have some patients with infection, we have some patients just with inflammation, then we have a different response. We have sepsis, that's usually a combination of infection and inflammation. The very severe one is septic shock, and a part of it, again, can result in DIC. We know DIC can also other reasons, like a malignancy, because we have also a situation that there are cells with tissue factor on the surface are in circulation. And that is against the concept of hemostasis. The concept of hemostasis, there should only be tissue factor, where is a damage to the vessel wall. But in infection, the monocyte starts to express tissue factor, and of course in malignancy, we have sometimes malignant cells. And therefore these patients both have a much higher rate of thrombosis than any other patients. So what can we do? And coming back to the group of Greece, that the same group who did the reference ranges in neonates, and they did the reference range because they wanted to learn, can we use ROTEM to identify neonates, which are sometimes not easy to identify whether really sepsis or not. What is the change in early phase of septicemia in these neonates? And what they could show was that if the extem clotting time is significantly prolonged, this was a quite good discrimination between just inflammation or sepsis. And we know if we treat every patient with just inflammation with a lot of antibiotics, there's a good chance to have a multi-resistant bacteria after a short time at our ICU. So we are between Scilla and Charybdis. If we treat too late, it's bad for the individual patient. If we treat too early or too many patients, we have a lot of problems that our antibiotics maybe not work anymore. So they said that this clotting time in extem was a quite good discrimination. So you get this information within 5 to 10 minutes, and it helps you to say, oh, this is just SIRS, wait and see, or this is bacterial sepsis. That doesn't mean give blood products. It's just a biomarker says, okay, hit them hard with antibiotics, because otherwise we run into problems. So again, this just summarizes that this clotting time, as well as clot firmness, was an early marker before platelet count was going down. We saw the change in function. So as a summary, said that ROTEM indicates as an early appearance of hypocoagulability, that this is a very good marker, and also about the degree of sepsis. So it's also a prognostic marker. So again, it's not used for guiding therapy with platelets. It's a biomarker for discrimination of SIRS and sepsis. It was not completely new. So we published this also in adults. So in adults, we could also show that as a biomarker, again, if we have a prolonged clot formation time, like a K time in TAC, or a reduced clot firmness, it was a much better prediction for mortality than a SAPS-2 or SOFA score. And you see if any of the parameters, clotting time, CFT or MCF or alpha, and we use the native test for these because it's more sensitive. XTEM is for speed, but the non-activated test is more sensitive. And then we even simplified and said if one of these parameters is below a certain level, you see that if they are normal, mortality was about 15%, and mortality was more than 40%. That is the first day of sepsis to discriminate about the severity of the problem and how aggressive we have to treat these patients. The other study we did was also, if you have patients with major surgery, and they come to the ICU, they have all inflammation. They have all the SIRS due to major surgery. The question is again, is that sepsis or just SIRS? And here we looked at different parameters, procalcitonin, some people are using this, and we use a shutdown of thrombolysis, which is an upregulation of PI1. So the discrimination odds ratio for proton was 6 and for lysis 85. So if we look at the ROC analysis, the area on the curve for procalcitonin is 0.75 and higher than 0.9. So a 90% chance to be right and 10% to be wrong for diagnostic tests is a quite good performance. And that was done here in Heidelberg. They also showed is not only a biomarker to differentiate, it also is a quite good marker for the prognosis of outcome. Of course, that doesn't mean we say, okay, this patient has a bad prognosis, don't do anything, it's just expensive. But again, that means if we want to have a chance, we have to treat them early and hard with antibiotics. And the others, we can be even more relaxed. It's a little bit like prophylactic plasma platelet, not put every patient on broad spectrum antibiotics. If the risk is less than 10% that this is really an infection problem, we do more a little bit wait and see, and the others we have to treat early and hard. And just coming back to platelet function analysis, it's also in sepsis, platelet function change much earlier than platelet count. So we are looking here, don't have the data, but again, and it's mainly the thrombin pathway, nothing to do with drugs, that if thrombin pathway is going down, again, a very good discrimination between just SIRS and sepsis. There's even a systematic review is done from the colleagues from Amsterdam. So it's not just from one single center, it's reproduced by others, that this fibrolytic shutdown, that's something which we actually discuss in trauma. If really every trauma patient has a hyperthrombolysis, maybe even some trauma patients have 2 less lysis, less than physiologic. So they don't die to exsanguination, they die 5 days later in multiple organ failure. So we are just learning about thrombolysis, and we need some physiologic lysis in our body because that's a cleaning system for the microcirculation. So even I think there will be some changes in the near future about what is the adequate amount of lysis in each setting. So again, to summarize, I think there are more and more data available that viscoelastic testing can be helpful in different settings. If we talk about prophylactic transfusion in pathologic standard lab tests, if we talk about bleeding management, we talk more and more about thrombosis management or avoidance of thrombosis or sepsis management. But in these settings, we still have to learn a lot. We're just at the beginning. What is important is, of course, in bleeding, we need data quickly. In other settings, maybe it can wait. And that is definitely important. It must be precise. It's not like guessing. It might be fibrinogen or platelet. And the ROTEM device is really designed to make the most precise diagnostic, because at that time we had already all the factor concentrate. We wanted to know is it really fibrinogen concentrate or PCC or platelets or plasma, what we have to give. Of course, the efficiency also depends on the therapeutic intervention. Diagnostic never improves outcome by itself. If a patient has a myocardial infarction, running an electrocardiogram doesn't fix the problem. Or if your patient has a broken leg, running an X-ray doesn't fix it. It helps us to do the right intervention. But of course, the more reproducible the therapeutic interventions are and quickly available, that's our experience with factor concentrates, not only in hemophilia, more and more used outside of hemophilia, makes it much more better calculatable, reproducible, and this is even much more important in children than in adults. Because in adults, you can more or less do like this, but doing this in pediatric patients quite often results in under or overuse. And very important, you need a reasonable protocol, which should be really based on evidence. As I said, patient blood management is an evidence-based approach. So it's not just an idea. It should be developed based on observational trials in a specific setting. What is really the requirements of our patient population in this setting? And I'm quite sure that a bone marrow transplant is different than a liver transplant, and a leukemia patient is different than a solid tumor. And we just, for example, recognize that platelet function in meningioma results is completely different than in colon carcinoma. So even the type of a tumor has an impact on the system. So that means we need really good protocols which are reasonable, and this is the link, the glue between diagnostic and therapy. And if these protocols are reasonable, and we have to learn more and more, then we have a good chance to improve patients' outcome, and that's the target of patient blood management. And thank you for your attention, and open for questions.